So this is the second in the podcast series of the child with malignancy and altered GU status. We're talking about treatment of children with malignancies. You're often going to see central venous catheters. You can have percutaneous, celastic catheters, implanted, PICC. Implanted devices are really good because they are permanent or long-term. You can access them and de-access them quite easily. They're often called ports, metaports, porticats, that kind of thing. The celastic has a dual lumen catheter with a cuff, so that's a different type of central venous catheter. Peripherally inserted central catheters, remember those are PICC lines. So we have all different kinds that we can use. Oftentimes we like the implanted type of catheter only because it's not something they can pull. It can stay for a long period of time. They don't keep it forever. They have to be accessed monthly. So once the child's stable, considered clear, they would surgically remove that catheter. So the results of the chemotherapy can be very caustic and cause what's called extravasation. Okay, so this is when the chemo is not able to differentiate between good cells and bad cells. We want to watch this happening. If this does occur, make sure that it is as small as possible and well cared for. It's really when the fluid or drug or the medicine leaks out into the surrounding tissue. Alright, so the first type of cancer we're going to talk about nervous system tumors. We're going to talk about the neuroblastoma. All right. The neuroblastoma is a problem, and the biggest problem with it is that by the time there are any signs or symptoms, there is about a 60% rate of metastases. So by the time they find this type of tumor, 60% of the time it has metastasized. It is an embryonal tumor. It is a type of cancer that affects immature or developing cells. It does sit right on top of the kidneys here on the adrenal medulla. It does affect the sympathetic nervous system because of where it sits. It does often affect children, mostly under 4, but more often than not, it is seen in children 2 and under. You might see this about 1 in 100,000 children. It is seen more often in boys than girls. The primary site is within the abdomen, as you can see right there on the kidney, but the metastases sites are head, neck, chest, and pelvis. Okay, so this is a picture of what the sympathetic nervous system handles. All right, it handles the fight or flight response. So if your adrenal medulla is affected, you know that the fight or flight response is impaired because of that, okay? And the effects when the fight or flight system overreacts, you're going to have increased heart rate, that relaxed bronchial smooth muscles, so those airways will open, increased metabolism, pupil dilation, decreased GI motility, peripheral vasoconstriction. Vasoconstriction is to keep the body's response to keep all the blood in the trunk and brain where all the vital organs are. Okay, so that's why it does that. With neuroblastoma, it will depend on the location and the stage of the disease, but the child may have firm, non-tender or irregular mass in their abdominal area. They will have this mass can cross the midline, so it can't, when it starts growing on that kidney, it starts growing towards the midline, all right, of the body. They will have urinary symptoms because the adrenal glands sit on the kidneys, all right. Facial symptoms include bruising on the face. You can see here what that looks like, and you can imagine that that might get mistaken for abuse, or it could be mistaken for trauma, like battle signs, right? They'll have lymphedema where the lymph nodes are, and they'll get kind of swollen and hard. They can have more vague symptoms like irritability, being tired, loss of appetite, and low-grade fever that is on and off, where they cannot put their finger on it. They will have catecholamines, which is a neurotransmitter that is produced by the sympathetic nervous system. It includes the dopamine, norepinephrine, and epinephrine, so those fight or flight response neurotransmitters. And this is going to affect their output. All right, so they are going to, because of this catecholamine response, they're going to have high blood pressure, heavy sweating, headaches, tachycardia, tremors, pallor, and dyspnea. As far as diagnostically, we are going to diagnose this by MRI or CAT scan. And you can see here, we're going to see that tumor above the kidney, all right? We are going to look for metastases in the neck, chest, abdomen, bone scan, do a bone marrow exam. The urine, we're going to check the urine for the catecholamines, okay? So we're going to look for that. All right, so the prognosis. So here is something very interesting. Inversely correlates to age. What that means is the older the child is when they get it, the harder or the worse the prognosis. So we talk about in respiratory, as the child gets older, their things develop, mature, open up, get larger. The anatomy, we talk about in the cardiovascular system how the smaller they are, the harder it is, the more at risk they are for when they're doing procedures and things like that. They try to wait for them to grow, so the risk is diminished. Well, in neuroblastomas and other cancers, the younger they are when they get it, the better the prognosis. For example, I had a young man, he's an older teen, probably 19 now, diagnosed with AML, so type of leukemia, right? He was sick and in the hospital for months and months. He was very, very sick. They were very worried about him. He had to drop out of college. He was on the basketball team. He had to drop out of basketball. He was hospitalized for months and months. His prognosis was not as good as a younger child's, but he did well because he was physically fit. But he had fevers for weeks at a time that they could not touch. Okay. Then my niece was born with AML, born with leukemia, and she spent 3 to 4 weeks at a time at Johns Hopkins getting treatment from the age of 4 days old. and she is completely clear with bone marrow, 100% bone marrow match, and recovering wonderfully, considered cancer-free, and she is now 7 months old. All right. So really, it makes a big difference about age. Staging is very important, especially with neuroblastomas. The stage will be done prior to any type of surgical intervention. The stage will often be based on, or let us know if it's metastasized. It will be based on how fast the tumor cells are proliferating, okay? It is considered a silent disease because one of the first signs and symptoms of a neuroblastoma is distension or abdominal pain. So, and again, remember, pain really is based on progression. So, unfortunately, with neuroblastomas, about 1/4 of the children who are diagnosed will die. Blood tests, when they do blood tests for neuroblastoma, they're going to show abnormal amounts of epinephrine, norepinephrine, and dopamine. And they're going to see in the urine the catecholamines, and that's the response to this type of cancer. As far as long-term effects, they are significant. A large percentage who are diagnosed and treated successfully do develop another form of cancer in their 20s and 30s. And when we are talking about therapeutic management and interdisciplinary interventions, we are talking about helping the entire family with psychosocial help, all right? We are talking about doing all the physical things, but also trying to keep that family from suffering more than they have to, from completely breaking. I mean, if you look at the studies of marriages that actually succeed with long-term illness or child death, it's not great. It's less, the odds are even more poor than what you would see normally. So it is very difficult for families, especially if it's with an infant. So it's very hard with small children and infants being diagnosed with cancer, right? They really don't, it's hard to see an innocent suffering like this. And when I say that, one of my students once told me that this is so difficult to deal with because you can kind of justify with adult and adult diseases. Oftentimes they have contributed to their risk factors of getting a lot of disease. Not always, but with children, they have done absolutely nothing. They have not done anything. They have not lived poorly. Like, there's no contributing factors as far as that's concerned. So it's very difficult to take. And you can see there's going to be altered coping for the family. There's going to be guilt associated. There's going to be anger. So, for example, teenagers can get very angry whether they're the patient or whether it is a sibling. You need to understand this and understand that's part of their coping. We need to offer the parents support. As far as our nursing process, we're talking about diagnoses, nursing diagnoses like pain, impaired coping, altered family process, risk for infection, obviously, right? And grief. You need to think about all these things when we are planning our care, all right? As far as end-of-life issues, if we get to the point where there's no options, we would do things palliatively. So to avoid hurt or further injury. So food and fluids are only used for comfort at that point. So we do not need to feed a child if they're not hungry in this situation. Pain meds are definitely given. Antibiotics you'll see being given. It keeps bacteria and other things away, so they are used palliatively. It also reducing infection also reduces the pain associated with that. So you will see antibiotics used for that. Excuse me. The next tumor we're going to discuss is called a Wilms tumor. This is also known as a nephroblastoma, a cancer of the kidney. All right. So Wilms tumor, you can see there again, forming from embryonic tissue that remains. It can affect one or both kidneys. The prognosis is best with children under 2. So again, we're still, anytime we're talking about childhood cancer, the younger the better. The early stage, just like other cancers, there are no symptoms. Tumors can get quite large, okay? If you're lucky, you can catch these tumors while they're still encapsulated, and then you have a better prognosis, okay? And they do stay encapsulated for a long period of time. As you can see here, stage 1, we're still within the kidney, as well as stage 2, still encapsulated. If you have approximately about a half of the kidney remaining, they may just remove the tumor and still keep the kidney. If there's less of that remaining, more likely than not, they're going to take the whole kidney. You can see here, stage 3, we are spreading outside of the kidney. And then stage 4, the spread is to other organs, okay? So what's going to happen here? Well, there's going to be an abdominal mass. We talked about it could affect 1 or 2 kidneys, but it doesn't often affect both. It usually just affects 1, okay? You can see here, surgery is the treatment, period. Follow-up can be chemotherapy and radiation, but that will depend on the stage and the aggression and all those types of things. Preoperatively, with this tumor, you do not want to palpate it. Palpation could rupture the tumor and cause the cells to spread. All right. One of the first signs of this tumor is an increase in abdominal mass, all right, or abdominal girth. So you'll often hear the first thing that parents notice is the child's clothes around the waistband getting tight and not fitting. All right. That's often what the first things you're going to see, okay? Diagnostically, you can see there the abdominal ultrasound, a CT. That's generally how you're going to diagnose this with a CAT scan. MRI, CBC, BUN, and creatinine, we want to see what the kidney function is, how the kidney function is. LFT, so we're doing liver function tests, and bone marrow depending on the aggression of the tumor. And you can see here how abnormally large that abdominal girth has gotten from that tumor, okay? As far as therapeutic management, you're going to see surgery, chemotherapy, radiation, frequent blood. So we talked about these, but frequent blood pressure monitoring. Remember that our kidneys are responsible for blood pressure regulation. So we have to be extremely mindful of that, okay? These are our nursing and considerations that we need to watch. Obstructions, obviously a focused assessment on our abdominal assessment, monitoring blood pressure frequently and very thoroughly, risk for infection, and maintaining that pulmonary hygiene so we don't have any type of respiratory complications. All right, as far as childhood cancer survivors, we have to manage the results of aggressive therapies, okay? Lots of children survive, but there are complications due to chemotherapy and radiation. So complications due to chemotherapy are cardiomyopathy, pulmonary toxicity, renal complications, hearing loss, cataracts, and infertility. These are all based on what is affected. I will tell you that based on the chemotherapy that my niece was given, her parents were told that she would never be able to have children. That was something that was very difficult for them to accept, that already you're telling them that that's not possible for their child. No parent wants to hear that. As far as respiratory, remember the lungs can be fragile, but so we need to maintain that pulmonary hygiene. Radiation can cause a linear growth retardation, so there might be impaired growth in those long bones, like leg length discrepancies and things like that. Osteoporosis from radiation, poor dental health. Neck radiation can cause hypothyroidism. Radiation can cause delayed puberty and sterility. It is possible for delayed neurocognition. That usually, they usually catch back up after treatment and the cancer has been resolved. Children who have survived cancer are more likely to have a second cancer. It is called second malignant neoplasm. So they're at increased risk for adult cancers, specifically colon, breast, and prostate. So we now know there are genetic markers that connect colon, breast, prostate, uterine, vaginal, those types of cancers. So when you go to the OBGYN office now, they're going to ask you if you have a family history of prostate cancer, and you're going to be like, why does that matter? Well, because of those genetic markers. It does predispose you to have an increased risk of some of those other types of cancer. All right. Now, this is right here, Mrs. Filburn, and she is the Director of Nursing for HAC Nursing, the HAC Nursing program. She also teaches pediatrics for Harrisburg and York. And this is her nephew. And her nephew had cancer in his bone. They actually removed his bone, and he did great. He was doing very, very good. And then about 3 months prior to his 5-year mark, because 5 years, they consider that cancer cancer-free. Okay, so 5 years without a recurrence, you're considered cancer-free. So 3 months prior to that, he started getting leg pain, and he went back, and it had returned, and unfortunately it metastasized, and unfortunately he did die. It was very difficult for their family. So, but that is Mrs. Filburn's nephew. If you remember when we talked about ventricular septal defect, her niece, and there she is, right? All right, and that was after the repair, obviously. We are going to do a case study together. And our next podcast, we're going to continue with our genitourinary alterations. Thank you.